Contents are surgical anatomy of trachea, bronchopulmonary segments, bronchoscopy and types, rigid and flexible bronchoscopy, and bronchoscopic procedures. The trachea is a continuation of the larynx at the infracricoid level. Average length is 11.8 cm. 17 to 21 incomplete cartilaginous rings that is 4 mm wide and 1 mm thick almost, that maintains its elliptical shape in adults, but the shape is more circular in children. The coronal dimensions in men and women are 13 to 25 mm and 11 to 21 mm respectively. The sagittal dimensions are 13 to 27 mm in men and 10 to 23 mm in women. With neck flexion, the trachea becomes almost completely an intrathoracic organ, coursing backwards and downwards from a subcutaneous position to rest ultimately on the esophagus and vertebral column at the level of the carina. Relations of trachea. The isthmus of the thyroid crosses the trachea at the second ring. The innominate artery crosses the mid-trachea obliquely from right to left. The arch of aorta indents the esophagus slightly and appears to shift the trachea towards the right, that is away from its midline position. Lateral structures on the right side are predominantly venous and include the superior vena cava, azygos, and right brachiocephalic veins. Lateral arterial structures on left side include the arch of aorta and left common carotid artery. Both right and left vagus, along with their recurrent laryngeal nerve and the right and left sympathetic trunks, are also laterally related to the trachea. Both right and left vagi, along with their recurrent laryngeal nerves and the right and left sympathetic trunks, are also laterally related to the trachea. These intimate relationships of the trachea with surrounding organs are of important concern when performing cervical mediastinoscopy with lymph node biopsy. This is a diagram showing the relationship of the trachea. All the venous structures are in the right side, and arch and other arterial structures are in the left side. Blood supply of trachea. Upper trachea is supplied by inferior thyroid artery. Lower trachea branches of the bronchial arteries. This blood supply is shared with the esophagus and the main bronchi. Anastomotic arcades develop on the lateral tracheal wall and feed transverse vessels that travel between the cartilaginous rings. So the trachea should not be circumferentially devascularized for more than 1 to 2 centimeter. The lateral arcades allow safe pretracheal dissections. Venous drainage is in inferior thyroid venous plexus. Lymphatic drainage drain to the posterior inferior group of deep cervical nodes and two paratracheal nodes. This is a diagram showing that upper part is supplied by the thyrocervical trunk, which is coming from subclavian artery and giving inferior thyroid artery, which is supplying the upper part of the trachea, and lower part of the trachea is supplied by upper left bronchial artery and lower left bronchial artery, which is coming directly from the descending thoracic aorta. The trachea bifurcates at T7 level into the right and left principal bronchi. The right is a more direct line with an angle of about 25 degrees and passes behind the SVC to reach the hilum, where it is most posterior structure to pulmonary veins. The left is slightly smaller, leaves the trachea more obliquely at an angle of about 45 degrees, passes below the arch of aorta and the left pulmonary artery, and is almost twice as long as the right main bronchus, about 4 to 6 centimeter. The carinal angle can be wider in women and obese people, and it can be also wider in patients with bulky subcarinal nodal disease.
Is it T7 or T4? Where is your reference for this?
So Shields, I made this.
They've said T7?
Yes, sir.
Tracheal bifurcation occurs at the sternal angle, and sternal angle is at T4.
Oh, no, sir. It's T4 only, sir. Sorry, sir. I think it's my mistake. Sir, it's T4 only, sir. Sorry, sir. There are in right lung, there are two fissures, minor fissure and major fissure, which divides the right lung into three lobes. And in left lung, there is one fissure, that is major fissure, which divides the left lung into two lobes, upper lobe and the lower lobe. Right upper lobe has large anterior projections, three segments, smaller than left upper lobe. Right middle lobe has only one anterior projections and two segments, is wedge-shaped in outline. Right lower lobe lies inferior and posterior to the oblique major fissure, and it has five segments. This is the minor segment, and this is the major segment. Left lung. Left upper lobe is much bigger than the right upper lobe. Large anterior projection, wide cardiac notch, four segments, has lingula, which is small tongue-like and projection. And left lower lobe lies inferior and posterior to the oblique major fissure, larger than left upper lobe. The right upper lobe bronchus, also known as the eparterial bronchus from the lateral wall of the right principal bronchus about 1.2 centimeter distal to the trachea. The right upper lobe bronchus, about 1 centimeter in length, gives off three segmental bronchi as it makes almost a 90-degree angle with the right main bronchus and the bronchus intermedius. After about 1.5 to 2 centimeter, the right middle lobe bronchus arises from the anterior surface of the bronchus intermedius. The middle lobe bronchus is 1.5 to 2.2 centimeter long, bifurcates into lateral and medial branches. In right lower lobe, the superior segmental bronchus arises from the posterior wall of the bronchus intermedius as it terminates into basal stem bronchus that sends off segmental bronchi to medial, anterior, lateral, and posterior basal segments. The medial basal segments of right lower lobe arises anteromedially, whereas the lateral basal and posterior basal segments most often arise as a common stem. Left bronchus. The longer left principal bronchus bifurcates into the upper lobe bronchus that travels anterolaterally and the lower lobe bronchus where it continues posteromedially. The left upper lobe bronchus divides into superior and inferior divisions that supply the upper lobe and lingula respectively. The superior division of the left lung branches it into an apical posterior segmental bronchus and an anterior segmental bronchus. The inferior or lingular bronchus, which is the equivalent of a middle lobe bronchus on the right, is 1 to 2 centimeter in length and divides into the superior and inferior divisions. The lower lobe bronchus on the right side gives off the superior segmental bronchus as its first branch before the basal trunk continues for about 1.5 centimeter as a single trunk. Then this bifurcates into an enteromedial basal segment bronchus and a common bronchial stem for the remaining basal segments. Now, bronchopulmonary segments. This is the essential anatomic unit of the lung. That portion of lung substance that represent the total branching of a major segmental subdivision of a lobar bronchus, named for their topographic position in the lung. Individual unit has its own pulmonary arterial and venous supply. Segmental vein run in connective tissue between adjacent bronchopulmonary segments, and it can be surgically resected, that is segmentectomy. This is the diagram showing bronchopulmonary segments. This is the pulmonary vein, which is going peripherally, and in the center there is bronchial arteries and pulmonary arteries, making capillaries with the pulmonary veins. History is in 1932, Kramer and Glass coined the phrase bronchopulmonary segment. In 1939, Churchill and Belsey paved way to segmental resections. In 1949, 10 normal segments were given specific numbers by Thoracic Society. In 1960, slight modifications of nomenclature by International Congress of Anatomists. Airway progression. Trachea is 16 to 70 C-shaped hyaline cartilage ring, bifurcate at level of sternal angle, that is T4. Carina is ridge on internal aspect of last cartilage. Left main bronchus is longer, 5 cm, smaller diameter, more horizontal, makes an angle of 45 degrees with trachea, and it has two lobar bronchi. Right main bronchus is shorter, larger diameter, more vertical, and more susceptible to aspiration. It gives three lobar bronchi. This is the airway progression. Like There's one trachea, then divides into main bronchi. Then there's bronchioles, then terminal bronchioles, respiratory bronchioles, then alveolar ducts and alveolar sacs it forms. These are the respective diameter and cross-sectional area. Segmental bronchus divides into subsegmental bronchi. Segmental bronchus divides into bronchioles. Tubes smaller than 1 millimeter diameter called bronchioles. Smallest terminal bronchioles are less than 0.5 millimeter diameter, and bronchioles have no cartilage. Respiratory bronchioles, two or more branches from each terminal bronchioles with air sac buds. This is first level of gas exchange. Respiratory bronchioles end in alveoli. Pores of Kahn and channels of Lambert are present to connect. These are the 10. There are 10 bronchopulmonary segments of the right lung and 8 in the left lung. Superior lobe is divided into apical, posterior, and anterior segments. Middle lobe is divided into lateral and medial, and inferior lobe is divided into superior, anterior basal, medial basal, lateral basal, and posterior basal. This color coding is referred in, from this picture. Superior lobe in left lung, there is a apical and posterior join and form a apico-posterior segment. Then there is anterior segment, then superior lingular and inferior lingular. In inferior lobe, superior segment is there. Then anterior and medial are incorporated and form one segment, and lateral basal and posterior basal. This is a video showing the lung is various segments are there. So right upper lobe segment, 3 segments, right middle lobe, right lower lobe. The characteristics of bronchopulmonary segment, largest subdivision of lung lobe, pyramidal in shape with apex towards the root of hilum. Each segment is an independent respiratory unit. Each segment has its own separate artery, that is a branch of pulmonary artery, segmental bronchus, autonomic nerves, and lymph vessels. The segmental vein run in the connective tissue between adjacent bronchopulmonary segments. Thus, a bronchopulmonary segment is not bronchovascular segment as it does not have its own vein. Usually, the infection of bronchopulmonary segments remain restricted to it, although tuberculosis and bronchogenic carcinomas may spread from one segment to another. These are few endoscopic images just showing the vocal cord and glottis. Then this is a carina, which is showing the left main bronchus and right main bronchus with truncus intermedius, and this is the left right upper lobe bronchus. The truncus intermedius, this is right upper lobe bronchus. Now, bronchoscopic evaluation. It is a visual inspection of airway. Types of bronchoscopes are rigid and flexible. There are three rigid bronchoscope principle. There are three essential components: the barrel, proximal head, and visualization elements. This is the assembled rigid bronchoscope. This is the ventilation side port. This is the barrel, and this is the visualization channel. Rigid bronchoscope indications: examination and management of obstructing airway lesion in massive hemoptysis, retrieval of foreign bodies, suctioning of inspissated secretions, and obtaining tissue biopsy specimen of endobronchial lesions. Commonly used in adults, have an internal diameter of 6 to 13 millimeter, manufactured in various lengths from 33 to 43 centimeters. Initially, it provides only tunnel view, but these days it can also used with telescopic lens for better visualization. Illumination is supplied by a halogen light source. Both models have a ventilating side port permitting assisted ventilation. This image is showing the various sizes of rigid bronchoscope. The smaller one is used for pediatrics and the longer one is used for adult. Now, position. Patient to be placed in supine position with head slightly flexed in order to achieve anterior alignment of oral and pharyngeal axis, like how it is shown in the picture.
This is showing extension, not flexion.
Yes, sir.
So you haven't understood the whole process.
Yes, sir.
You flex the leg and then pass
Yes,
the
sir.
thing beyond, lift the posterior portion of the tongue, and then
Yes, sir.
visualize the epiglottis, and then gradually
Epiglottis.
extend the neck, and then go
Mm.
behind the epiglottis, visualize the
Yes,
cords,
sir.
and then push it into the trachea. That is the sequence.
Okay,
You have
sir.
not understood what it is, and you are showing a picture which is totally wrong from the thing that you've written there. Go ahead.
Once the vocal cord is visualized, the scope is rotated 90 degrees with the bevel parallel to the cords to prevent any trauma. After passing cords, the 180-degree rotation of the scope is completed while smoothly advancing the scope to mid-trachea. Patient's upper teeth should be protected with the operator's thumb or fingers, and cords should be viewed by anterior displacement of scope rather than lever motion on the teeth.
Have you
Limitations.
understood what have you understood what it means?
Yes, sir.
Have you seen a rigid scopy?
Yes, sir. I've seen, sir. Once I was in thoracic posting, sir. You were only doing it.
But you have not written down the steps, I'm sure. Because if you had written down the steps, you would have known. Hmm?
Yes, sir.
Okay.
Limitations are always performed under GA, and sampling of upper lobe and distal airway cannot be accomplished easily. No, flexible bronchoscopy. Performed in dedicated area of hospital, IV sedation is routinely used. A portable cart supplied with a light source, bronchoscope, and accessories is a convenient way to perform it bedside. Indications for diagnostics: severe cough or any change in cough pattern, hemoptysis, wheeze, unresolved pneumonia, abnormal sputum cytology, diffuse lung disease, bronchoalveolar lavage, bacteriological sampling and opportunistic infections, metastatic malignancy or upper esophageal cancers. Diagnosis and management of lung abscess, suspicion of airway trauma if wheezing, hemoptysis, or subcutaneous emphysema is present in trauma patient. It can be because of torn bronchus that can be easily visualized on bronchoscopy for early repair. After inhalation of caustic fumes or smokes, require frequent bronchoscopy to clear out necrotic tissues for days as it progresses and lead to late airway obstruction. Gold standard in diagnosis of acute pulmonary allograft rejection or infection in post-lung transplant. For therapeutics,
These are
yes, sir.
these are the least used indications for fiber optic bronchoscopy. How often have you seen a inhalation of fumes and smokes, and then pulmonary allograft rejection is done much later in a trunk transplant? We don't, every unit does not do lung transplants, and
Yes, sir.
bronchoscopy is much more useful in the initial evaluation of a donor. All those
Yes,
things
sir.
are not mentioned. You have mentioned some funny indications and saying that these are the indications. Hmm. Okay.
For therapeutics, atelectasis, lung abscess, foreign body removal, in cystic fibrosis patient to clear out persistently thick tenacious secretions, in strictures and lasers.
What do you mean by lasers?
So for laser ablation, we can use.
Okay.
Flexible bronchoscope advantage is it is patient friendly, like patient comfort is there. Segmental and lobar visualization is good. Segmental biopsy we can take, peripheral biopsy we can take, transbronchial needle aspiration, bedside aspiration of thick retained secretions. Bronchoscopy on ventilator we can do, can be passed through narrowed and distorted airways or beyond and obstructing lesions. Photography and increased cancer diagnosis and brachytherapy we can do. Disadvantages are small channels can be very sophisticated in these instruments are, so breakdown is easy and sterilization. This is a image of this flexible bronchoscope. This is the insertion tube, bending rubber. This is the body, the working channel port. This is thumb control lever for tip motion. This is a suction port. This finger activated suction valve, and this is the light connecting light source connection. There are various sizes, range from a 6.2 millimeter outer diameter, that is 3.2 millimeter working channel, to 2.7 millimeter. Most often used 5.9 millimeter, allowing clear visualization and specimen sampling throughout till 4th to 5th order bronchi. Forward field is 120 degrees, angle of deflection 180 degrees upward and 130 degrees downward.
I'm on a camera here. Go on, go on. So
Yes, sir. This this is the tip of the flexible bronchoscope. This is the optic center with lens. Metal housing is there. These are the light source. This is the suction channel. The mm, various sizes of bronchoscope. This is out. A is the outer diameter of 3.8 millimeter, working channel of 1.2 millimeter. This is outer diameter of 5.4, and this one is 5.8. Bronchoscopic procedures. Diagnostic bronchoscopy, foreign body removal. We can do bronchoalveolar lavage, EBUS, TBNA, autofluorescence bronchoscopy, endobronchial brachytherapy, airway dilation. Diagnostic bronchoscopy. For initial examination, visualize larynx and vocal cords, detect unsuspicious leukoplakia, carcinoma in situ, and invasive carcinoma. Assess vocal cord mobility. Recurrent laryngeal palsy due to lung carcinoma usually indicates inoperability. There is bronchial brush cytology also we can do. Rapidly smear bronchial brush onto a glass slide and immediately immerse in 90% ethanol for cytological examination. Then we can do systemic examination. Examine all lobar and segmental bronchi thoroughly. Identify potential secondary lesions that are not visible on chest radiograph. And you can assess tracheobronchial tree remote from the suspected area first to avoid cross contamination. Then we'll do detailed inspection. We'll examine the bronchus leading to the known disease area. There is characteristic of secretion and bronchial mucosa. We have to notice. Look for mucosal abnormalities. Is like if there is any thickening, irregular fold, corrugation, irregular vascularity. Observe for loss of definition in cartilaginous rings or any bronchial stenosis or extrinsic distortion. Record the extent and precise location of findings, especially if surgical intervention is planned. This is a video showing the like how they are taking the biopsy.
1 minute. How do you differentiate upper lobe versus lower lobe bronchial openings? As you pass a bronchoscope through,
Yes, sir.
you will start seeing the division of the bronchi into different branches.
Yes,
You
sir.
may be, and if you keep following without knowing where you are lost. So you have to come back to the original point and then
Yes, sir.
carina, then go on to the different major bronchi, and then subsegmental bronchi. How do you differentiate upper lobe from lower lobe?
Sir, from the like the bronchus is going upward. That
your bronchus can get rotated. Somebody else can rotate your bronchi piece, and then the whole bronchus is looking at an inverted image.
Yes, sir, that can happen.
So what I'm trying to say,
Yes,
Chavi, is
yes,
you've just picked up an article in a book, just cut and pasted a few lines here and there without
body removal. It is more commonly used. Rigid bronchoscopy is more commonly used for foreign body removal. Advantages are due to better exposure and airway control, and it is preferred instrument especially for infants and children. In flexible bronchoscopy, risks are potential complications include losing the foreign body or it get misplaced, it moves distally, impacting it or causing airway bleeding. Use of grasping forceps, snares, basket and balloon tipped catheters. Combination approach is also done. Combining flexible and rigid bronchoscopy can enhance detection and retrieval rates, especially useful for foreign bodies lodged in the distal airway or upper lobe bronchi. This is a video, sir, showing this foreign body removal. The grasper is holding the foreign body and removing it. Or bronchoalveolar lavage. Bronchoalveolar lavage.
One sec. It looked very nice on the video, but you should know the technical details, how it is done.
Yes, sir.
Huh?
Yes, sir.
Whenever you are removing a foreign body which is bigger than your scope, you have to use a particular maneuver so that you bring all of them together out. All that is you have not been saying. How do you remove a foreign body with a rigid scope? How do you remove a foreign body in a fiber optic scope? Okay.
Bronchoalveolar lavage. Utility and indications: recovers material from terminal bronchioles and alveolar sacs. Low risk procedures with high diagnostic value for certain interstitial lung disease. Can avoid surgical lung biopsy in diagnosing alveolar proteinosis, alveolar hemorrhage, bronchoalveolar carcinoma, and Langerhans histiocytosis. Diagnostic role: it provides additional information on ILDs when combined with clinical and high resolution CT findings. Fibrosing conditions characterized by neutrophilic and eosinophilic bile. Granulomatous diseases are characterized by lymphocytosis. CD4-CD8 ratio determination useful in sarcoidosis and hypersensitivity pneumonitis. Also assess unspecific filtration, infection, and rarely malignant diseases. Procedure: wedge tip of flexible bronchoscope into subsegmental bronchus. Irrigate and aspirate with 20 to 50 ml of sterile saline. Prefer middle lobe and lingula in diffuse lung disease for better recovery. Instill total 100 to 300 ml of saline, from which we recovers only 40 to 60% of volume. This is the video, sir. Is instilling the saline into the bronchus, and then the sample is taken from that saline, which is mostly 40 to 60% of the instilled total saline.
What's the difference between bronchial washing and bronchoalveolar lavage?
Sir, in lavage, we get only 40 to 60% of saline. In washing, sir, we remove all the saline.
Is it? How will you do that?
Sir, exactly. I'll read, sir.
You are presenting a seminar, madam. When will you read? And when will you, all your audience have not understood what you have been saying? It's an important differentiation. It is like pulmonologist terming any air leak as BPF. It's not so. BAL is not bronchial washings, and they cannot be used interchange.
Yes. It is more lesion directed, sir. In specific area, we do.
Is it? Just don't talk out of your hat. You said you don't know. Accept that. Go back and read.
Okay, sir. Microbiologic specimens used for immunosuppressed patient fungal, bacterial, and viral cultures can be easily acquired. High diagnostic yield, more than 85% of pneumocystis carinii pneumonia in AIDS patient. And the potential side effects can be bronchospasm, hypoxia, transient fever, and transient decline in.
Why? See, hold on. This is
Yes, sir.
what I'm saying, that you people just copy and paste from a book. In our country, tuberculosis is the most important thing. You have not even
Yes, sir.
mentioned tuberculosis. You just copied from some book written in the West. Huh? It's got to be some common sense, madam. Go on.
Endobronchial ultrasound. EBUS technique advanced mini probe into target bronchus observes snowstorm image for air-filled alveolar tissue, identify solid tumors with homogeneous hyperechoic margins, remove ultrasonic probe to introduce biopsy instruments, presenting methodologic limitations, overcoming EBUS limitations, use EBUS with a guide sheet to leave the working channel in place for biopsy instruments, use fluoroscopic registration to guide biopsy instrument to the target lesion.
Have you even understood a single line of this?
Yes, sir.
Huh? Can you
Yes, sir.
explain to me what is mini probe, target bronchus, what is snowstorm image? Can you tell me that?
Sir, because it is a ultrasound guided biopsy. So when we put the probe, ultrasound probe inside the bronchus, we look for lymph nodes, which mostly it is if it is air-filled alveolar tissue, it will show as a snowstorm, and then we'll target those bronchus.
How will air fill a lymph node? You're talking about two different things. Obviously, you don't have a clue. And what is this? Remove the ultrasonic probe to introduce biopsy instruments, presenting a methodological limitation. Have you seen any EBUS being done? Have you seen the equipment on the EBUS?
No, sir, that I've never seen.
Then
Not seen.
the ultrasound probe and the biopsy needle are in the same this thing, same tip.
Yes, sir.
Under ultrasound guidance, you introduce the biopsy needle and take a sample.
Sample, yes, sir.
Chavi, you have not done any homework on this presentation. I'm extremely disappointed.
Sorry, sir.
Okay. No, this is not this thing. It's not for my benefit. It is for your benefit and your learning. If you do a shabby thing and then just go away with this, you have no clue what you're talking about. Go. I don't have to learn how to do bronchoscopy. I have done that for 45 years. Go on.
Yes, sir. Diagnostic yield improvement. Previous low diagnostic yield for small pulmonary nodules, less than 2 centimeter. Recent advancement EBUS guide sheath have improved diagnostic yields. Most widely used for peripheral lung disease, produces 360-degree real-time ultrasound image via rotating piezoelectric crystal in a flexible catheter, effective for assessing peripheral lesions and airway wall layers. Transbronchial needle aspiration. It's popularized in mid-1980s by Wang, useful for sampling subcarinal and paratracheal lymph nodes and widened spurs. Preoperative imaging is use of CT and MRI to define lesion and assess proximity to major vessels. Performed on outpatient basis under conscious sedation or general anesthesia with a rigid bronchoscope. Advanced needle sheath beyond bronchoscope tip. Extend needle 1.5 cm through trachea or bronchial wall into mediastinal mass or lymph nodes. The knowledge of adjacent major vessel is essential to avoid complications. Then reinsert needle multiple times with gentle suction and avoid suction when needle is fully withdrawn. Real-time procedure with high diagnostic yield, less dependent on bronchoscopy expertise. Use of 7.5 MHz convex transducer at 1035-degree angle and 80-degree angle of view. Equipped with power Doppler and color Doppler modes for safer sampling. Use dedicated 21 to 22 gauge needle through 2.2 millimeter working port. Then lymph node assessment. Sample nodes if more than 1 centimeter in short axis, round shape, heterogeneous echogenicity, and lacking HeLa structures. Then international lymph node map is used for identifying lymph node stations. And if these criteria are met, then there's high suspicion for malignancy. Advantages are minimally invasive, precise and safe evaluation of mediastinum and HeLa region. Coverage includes cervical mediastinoscopy plus HeLa lymph nodes. Alternative to
Hyler, talk
HeLa
like
lymph.
a surgeon. Talk like a surgeon. No, nobody calls it healer. Hyler. Have you not heard this term before?
Yes, sir. HeLa lymph nodes.
Hilum of the lung and hilar region.
HeLa, yes, sir. Alternative to mediastinoscopy for mediastinal staging of non-squamous cell lung carcinoma, high diagnostic yield for lymphoma and sarcoidosis.
No mention of tuberculosis again.
And
You just copied and pasted from an Western textbook.
yes, a tuberculosis. This is
The
a
commonest cause of
causes
mediastinal
of
lymphadenopathy is tuberculosis in our
tuberculosis.
country.
Yes.
You not even mentioned it. Go on.
Autofluorescence bronchoscopy. It utilizes the helium cadmium laser or filtered xenon lamp illumination with blue light. In vivo spectroscopy with an optical multi-channel analyzer helps identify area of severe dysplasia and carcinoma. Pathologic area exhibit decreased autofluorescence intensity due to thickened epithelial layers, contrasting with normal mucosa predominant short wavelength fluorescence. Longer wavelength fluorescent light diffuse preferentially horizontally from adjacent normal submucosa, causing pre-malignant and malignant epithelium to appear red. It is used for screening and diagnosis of high-risk patient for malignancy. Procedure is sputum cytology, initial screening method. Surveillance bronchoscopy we do just preferred to establish the diagnosis and localize the pathology. The examination of mouth, pharynx, larynx, and tracheobronchial pre-examined for early carcinoma. Technique is illumination, helium cadmium laser or filter xenon lamp with blue light. Optical multi-channel analyzer used during bronchoscopy for in vivo spectroscopy. Detection is severe dysplasia and carcinoma, which is identified by decreased autofluorescence intensity. Normal mucosa appears green under blue light, and any pre-malignant or malignant epithelium, if present, it appears red due to horizontal diffusion of longer wavelength light. This is the image showing red light is showing the pre-malignant lesions, and green is showing the normal mucosa. Endobronchial brachytherapy. Localizing ionizing radiation for airway palliation. Procedure is catheter placement. This is polyethylene after loading catheter placed via transnasal flexible bronchoscopy. Position is confirmed bronchoscopically and fluoroscopically both. Radioactive seeds, typically iridium 192 used for treatment. Mechanism is DNA damage. Ionizing radiation induced DNA damage leading to apoptosis of tumor cells. And in treatment field, depth usually around 1 centimeter radius from the catheter. Applications are in palliation, advanced and unresectable cancers, symptom management, effective for hemoptysis, dyspnea, and pneumonia. Benign conditions are decreases recurrent granulation tissue in benign airway stenosis. Now, airway dilation. This technique, rigid bronchoscopy, is used for sequentially large scopes we put and dilate it slowly. And bougie dilators also we can use. And there is balloon dilators, which is flexible, which is done through flexible or rigid bronchoscopy both. Various diameters and lengths are available. Use of guide wire for tight stenosis is helpful. Inflated to manufacturer recommended pressure. Rigid bronchoscopes allow continuous ventilation also, so it can be done easily with that. Bougie and balloon dilation cause temporary airway obstruction. Potential loss mucosal trauma with gradually dilation can happen. Outcomes and complications, immediate symptom relief and limited long-term efficacy. Common complications are airway lacerations, which is usually superficial. Multiple dilation may require stenting or tissue ablation, and improved patient selection for better long-term outcomes. This is a balloon dilation. It is showing vision of this. The complications of bronchoscopy, major complication often due to pre-medication and topical anesthesia. Then there is bleeding. Correct bleeding, for that we have to correct the bleeding disorders, if any, by anticoagulant reversal or platelet infusion. Ensure prothrombin time to be more than 40% of normal and platelet count to be more than 50,000 per ml before brushing or biopsy. Avoid brushing and biopsies in patients with uremia or pulmonary hypertension. Use topical epinephrine to minimize or control bleeding. For endobronchial hemorrhage, wedge the scope in the segmental bronchus and apply suction. Measure for massive hemoptysis. Rigid bronchoscopes are preferred as it clears out the bleeding and simultaneously it maintains the ventilation also. Once bleeder is identified, we can either do adrenaline soaked plaget we can put there, or we can stop it with electrocautery, or we can do cryoablation. Fogarty balloon tamponade we can do, or bronchial artery embolization can be done. Other complications are pneumothorax, which occurs in up to 3% of patients undergoing transbronchial lung biopsy. Then bronchospasm and laryngospasm can happen. This is common with asthma and severe COPD patients. So we have to give pre-medications like corticosteroids or bronchodilators before doing any procedure. Infection control is important. Special care and appropriate sterilization are needed for patients with hepatitis, HIV, or suspected tuberculosis. Specific contraindications are avoid bronchoscopy in patients with bilateral vocal cord paralysis to prevent any airway obstruction. Caution in patients with tracheal obstruction, avoid biopsy or dilation unless prepared for rigid bronchoscopy or surgery. That's also. Thank you.
Well, as I told